monthly meeting. Um, Thank you for starting the recording. Appreciate that. So, welcome to CMDA or Pulp Med Colorado as we are making this transition to a new name and logo and all the things. Today we have a few people joining us. So, we're going to start off. We're going to start with Lacey. I'm not going to say your name right, Lacey, but you,
I
Cornelson,
can.
is that right? And
That's right. You did well.
perfect. Okay. You are joining us from Kansas State University, correct? And you're going to tell us more about the moving forward. There's a nursing home coalition that's talking about goals and preferences for residents, and we wanted to share with our members.
Yes, thanks for having me today. I also, Addie Van Zetten, the project coordinator for this, is here with me. And so we, what we're doing right now is recruiting nursing homes to participate in a second pilot phase of the project. And so that's what we hoped to get your help with. As you are probably aware, if you work with nursing homes, that some of the top deficiencies for nursing homes relate to comprehensive care planning or the care plan not matching what happens or not reflecting who the person is in a meaningful way. And so the Moving Forward Coalition really focused on that aspect of person-centered care and developed a guidebook. And I might share my screen just for a minute so you can see the resource a little bit. Um, so bear with me for a second. Um, so this is already publicly available, and the first year of the pilot was to really test this with a few homes and perfect it a bit. Um, and it's really a how-to manual for really putting the resident's voice more central to their overall care. Their goals, preferences, and priorities, directing what happens to support that person in the nursing home and support whatever chronic conditions they may have related to their goals. And what I think is really important about this guidebook is it's practical, it has steps and tips in it, and it has tools and resources that can be put into place right away. It's not meant to override systems that are already in place, but to improve upon those. It's a really customized kind of process. So this is available online. It has tools in it like something that homes can customize and put in their welcome packet for residents about what to expect for a care plan, what's their role in the care plan, what's the home's role in the care plan. And I think another ulterior motive to it is it really lays out a process that's very collaborative and has the resident's voice at the center so that it sets the expectation for the home about what they could do to improve their care planning processes potentially through their work on this. It has tools like a quick reference sheet that not only includes some basic clinical information about the resident and care information, but also preference information that all people who might work with that resident on a daily basis could look at. That would be helpful. So we're looking for more homes to participate in the next pilot phase, teams that might be motivated to improving their processes with this, homes that have some leadership who would be supportive of this and are willing to collaborate with our team that has expertise in this. Addie is directly involved in the last pilot group, we did focus groups just about people's experience, and overwhelmingly, it was very positive. We have a statewide conference, and one of the participating homes spoke up in the conference and said, You should really work with Addie. It was an amazing experience. So, these are some of the things that people said. There's a self-assessment for the homes that they start with that identifies what are your current practices, where are the gaps. Addie works with the homes to figure out what gaps are and what the home might be interested in improving upon. And so they decide that, and then she walks them through developing an action plan or a strategic plan um, to get ready for implementation changes around those things. And then she provides technical assistance through that process with those teams. And so that's what they would be signing up for. So if you know of homes that you might work with or in your sphere that might benefit from this, we encourage you to reach out to Addie with the home's name, the contact person there, and their phone number and email address, and Addie will just reach out to them and see if they might be interested and tell them more. And that's all I've got. Does anybody have questions?
Lacey, could you put Addie's email in the chat as well?
Yes.
Thank you.
Well, perfect. Thank you so much for sharing your resource with us. I mean, that's the reason we all do the work we do, right? To be patient focused and make sure we're honoring wishes for people. So thank you for sharing that. Hopefully we
Yes.
have people who are interested in partnering too. That'd be great.
Yes. Well, thanks for the opportunity to talk to this group. Really appreciate it.
Yeah, thank you so much, Lacey. Appreciate you
Okay.
joining us.
Yep. Addie and I will step off now. Thank
Okay,
you.
thank you. All right. Well, next up, Jenny Albertson, would you like to join us for your updates? I have your slides, unless you would like to share yourself.
I can go ahead and share those. I'm on it. All right. Okay, there's a couple of things very particular to this audience today, so I have tailored this for you all. HHS, of course, is back in full operation after the government shutdown. I wanted you all to be aware that though some things continued without interruption during the shutdown, there were some things that are going to be a slow restart. So we have about 51% of our communities currently past the 18-month mark for their annual recertification survey window. So if you're waiting for an annual recert at one of your buildings, it could be a bit. 51% is a lot to catch up on. Their usual amount is closer to the 25 range, and now we're upwards of 100. So it's significant. It's going to take them a while, and this comes in conjunction with them integrating into a new federal system through the Aspen database. And so there's a lot of data load that's been happening behind the scenes that is also bogging down processes. But there are new 2567s coming through now that also might catch them up. I'll touch on some things you should watch for on those. Also, we saw telehealth waivers restored through the restoration of the government funding. So unfortunately, this did not go through originally when we wanted it to with renewal process that would have been normal, but at least they went back and restored physical therapy, occupational therapy, and speech language pathology for telehealth eligible services. It also allows some delay in in-person requirements for mental health treatments, and it removed some geographic limitations for telehealth. So that's wonderful. Hospice recertification also can be done through telehealth now. So here's the 2567s or statements of deficiencies concerns that we're seeing across the country. There are issues around end dates of surveys. Sometimes they are sending them to set the date of the letter issuing, which happened after the shutdown, rather than the actual date that the survey was conducted and they exited. So even if your survey took place right before the shutdown, you never got your 2567 in letter. Now you're getting one, but it doesn't represent that it was done before the shutdown. It represents a later date. There's an advantage to that in the sense that you may have a little bit more time for compliance dates or a little bit of a delay in penalties. But what we're also seeing is that they're shortening compliance periods. So you would normally have seen, a 90-day period for some corrections. They're shortening it to 30. So anyway, look very carefully and advise your administrators to look very carefully at their statements of deficiencies and their letters. Penalties are being altered to correspond to the shutdown ending also. So hopefully that's to folks' advantage, but in some cases it may not be. It depends on their circumstance. We do still need an update on our COVID policy at the national level. Colorado has decided at the health department level to comply with CDC requirements, despite the stagnation in their vaccine advisement process. So even though PultMed's been wonderful about giving us new guidance around vaccination, we're still having to be compliant with work restrictions, for people that have tested positive. It no longer jives with what we're doing for flu and RSV. COVID is a completely different set of requirements for skilled nursing settings. It's just very disparate and confusing for folks. We really would love to see them come in line with the HCPAC recommendations. The other piece is that we no longer have a viable up-to-date definition. That expired in September, and so we're waiting for them to change that to match the new recommendations for the current immunizations. The federal loans, you may have heard a buzz. The way people are sending it around the internet and social media is nurses are no longer considered professionals, and everyone's very indignant about that. Despite the nomenclature, it really does have a real world consequence. So federal loan eligibility is based on classifications of potential professional certifications and licensure and degree programs. Department of Education has said that they need to comply with the new HR1 or Big Beautiful Bill, and that bill required them to alter drastically the eligibility for professional classification and qualifying for federal loans. What they've ended up doing then is putting a professional degree categorization that excludes advanced practice nurses, OTs, PTs. Essentially, it's a deterrent to coming into our care force because it caps their annual loans for new borrowers at $20,500 for graduate students and a $100,000 aggregate limit with only $50,000 available annually. So it's really significant for people that are paying for very difficult and costly school, also while they are going to probably work through the process. So it just seems like it's sort of vindictive, but I think it might actually just be not understanding the ramifications of what they're doing. It is going to be a significant deterrent for getting people new into the profession. There are links to articles there for further information. This one's specifically for you all. Medicare participating physician or supplier agreements expired. The form itself expired. The Office of Management and Budget has to approve all of these federal forms, and they are hanging on to this one. It expired November 30th, and they have not released a new form. They want to continue to accept the current version if it's dated after November 30th, but keep your eyes peeled because they're going to be releasing a new one, and you will need to complete a new one to be a Medicare biller. Quick little update on the regulatory side. I've been attending, and many of you have. Dr. Eber, I see you there every time. Thank you. The stakeholder meetings on our regulatory revision and rewrite for Chapter 5, which is specifically for skilled nursing and long-term care in Colorado. There were some pretty significant changes in the last meeting, things they're working on to revise, and nothing's set in stone yet. We have months left. We have months left before this is all finalized, but I want you to know what the moving targets are and what we're kind of going to bat around. They are allowing for the same restrictions that they allowed in assisted living regulation rewrite last year on visitation to comply with public health issues, infection control, those sorts of things. It also applies to drug trafficking and statute or law requirements when we're restricting visitation specific to something that's come out that's beyond our own level of authority. So that's a good rewrite. The policy and procedure for each building has to reflect a broad set of circumstances that would fit those requirements. So you do have to have a policy and procedure for it and let people know what the restrictions might be. I would highly suggest that you encourage your QAPI team to look at their policy and procedure for visitation and build things in that will protect your residents in events of criminal activity, drug trafficking, violation of various safety concerns. And then the language also includes numerous definitions of people designated by the residents. So this is something we're going to need to work on. There are a lot of people that a resident is supposed to name according to the new regulatory language. And I think it's a little cumbersome. So we might look at some legislation there. And then they've added discharge language updates, which essentially I'm hoping will incorporate an omission that is in the CMS federal guidance, which is that you can discharge someone when they no longer need your level of care. We actually don't have permission to do that by Colorado regs. We can discharge them for a lot of other reasons, but never that they no longer need our level of care. So it's pretty absurd, and we're hoping to get that one fixed. And then just a quick note, these are the education opportunities coming up in January, February. We kind of go on a hiatus because we don't get participation in November, December. So back in January, and I will be going over discharge regulations at that time in a seminar on the 6th. That should be pretty widely interesting. And then we also have Alan presenting for us the 13th on sexuality and dementia, balancing resident rights and safety. And that's what I had. Thank you.
Awesome. Does anyone have any questions for Jenny? I did have a question in the Christina Lilbroca. She asked, or Christine Lilbroca asked if PAs were impacted, and PAs were, as well as PT, OT, speech therapy, with this designation for a professional degree. So it's super challenging as I can't even imagine, like my paying for med school was very expensive when I went through. So I can't imagine going through school now and then not having the resources with the loans and being able to come out on top with that. So hopefully things will get better. So, okay. Well, thank you so much, Jenny. We appreciate your insights as always.
You
So
bet.
I see Chad is here from Chad Fear from CDPHE, and he has a few updates for us as well.
Good afternoon. Just wanted to, I guess, touch base on a few of the things that Jenny also had mentioned. So I appreciate her. I don't have slides, but I really like her slides. Anyway, mine end up being government gray anyway. So did want to piggyback a little bit on what Jenny was talking about, that we have received guidance on completing overdue work that could not be completed during the shutdown. We call it our parking lot. Where we put pause work, and this includes processing surveys with less than harm findings. We've been writing citations, preparing deficiency lists, and processing survey letters for 92 surveys. That's what we had on pause. I think you'll find that the 000 tags, so when you get your report, that's usually the first in line. That will have the actual X, should list the actual exit date of the survey. However, the survey letter should provide the clock date, if you will, which establishes the time frame for submitting your plans of correction. The CMS deadline for us resolving this paused work is December 12th. And I know we've been working very quickly to try to get this stuff out, so it's not just a big mail dump, if you will, on December 12th. So if you haven't received the deficiency list or letter and you are expecting one, it should be sent to you shortly. As Jenny indicated, we are resuming now our recertification work, and we are challenged with the task of bringing facilities current in their survey cycle. We do have an extensive list of facilities that are overdue, and overdue for us means anything beyond 15.9 months from the previous recertification survey. And into the future, once we've been able to bring everything current, we have to achieve a 12.9-month average. So we're working hard to quicken our pace. Part of that has been dependent on bringing in new surveyors to fill vacancies and getting those folks trained so that we're able to go in and conduct a reasonable survey and seek to understand, if you will, the facility's intent to comply with regulations. Okay, so speaking of regulations, we have many state rules that often correspond with federal regulations. And we have many times incorporated state licensure and federal surveys together. Unless harm was present, we only issued one deficiency report, with the federal regulation being listed. Unfortunately, this practice has made it difficult for us to show that we've been meeting our obligation to determine compliance with state licensure rules. So in response to that, and starting December 1st, so yesterday, we are implementing a process to document when state and federal surveys are conducted at the same time. So examples of that would be complaints that are not facility reported incidents. FRIs will be reviewed under federal regulations only, and annual surveys, but on a rolling basis, as state rules allow up to 3 years between relicensure surveys, and this is dependent on a facility's history with compliance. When state and federal surveys are conducted at the same time, the facility will receive 2 deficiency reports, and will have to submit 2 plans of correction. Now, often you're going to see, the same deficient practice on the federal report. It will be the same, because they're corresponding, the same issue with a state licensure rule. And I think that most facilities are familiar with the practice of getting 2 deficiency lists when there had been harm cited. And essentially, I think that your response is going to be the same, I would imagine, for noncompliance, regardless of whether it's a state rule or a federal regulation. So oftentimes those end up getting copied and pasted. Now, there are a number of state rules. I think as the group going through the Chapter 5 could attest that there are some things in state rules that is not supported or doesn't have a corresponding federal regulation. So those would be standalone on that deficiency report, that you have the list of state rules or concerns with compliance with state rules. Now, without making this too complex, there is also a state rule that allows for facilities to correct low-level deficiencies prior to the survey's exit. And our TCs will be working with facility leadership to try to work through that process. There is not the same opportunity to correct for federal regulations or for federal citations, so that would end up on the deficiency report. We're doing everything we can to not make this cumbersome, but we have to have a way to represent that we are conducting licensure, having licensure events alongside the federal events as they occur. I think the only other thing I had, there was a question that I received, and that was about an increase in abuse tags related to the use of PRN psych meds. And did just want to bring to the group, the update for that. The regulatory language for both routine and PRN psych meds was moved from F758 several years ago, and placed under, or at least our consideration of, chemical restraints. We were provided that guidance several years ago, and with the most recent update of the state operations manual, those requirements were moved to F605, chemical restraints. And that reads, every resident has the right to be treated with respect and dignity, including the right to be free from chemical restraints imposed for purposes of discipline or convenience, and not required to treat the resident's medical symptoms. And yes, F605 is right smack in the middle of the abuse regulations, F600 to F610. So that's where we see it now. So it's not that it was an increase in the number of those types of concerns. It's just that it was moved from a psych med regulation, standalone regulation, and it was moved under the chemical restraints. And as a result, facility being flagged, it may result in the facility being flagged with a red hand for serious or repeat deficiencies. That's what I have for you today, and thank you.
Thank you so much, Chad. You just You and Jenny always have a breadth of knowledge. I always learn something every time you guys come on, so we really appreciate you sharing all that with us. So thank you. Of
Rebecca, could I ask a quick question? This is
course.
Christine. Chad, does that get cited if there is in fact evidence that the drug is being used as a chemical restraint?
Yes, and oftentimes it is either not following the requirements around the use of a PRN psychotropic medication or a PRN antipsychotic medication. We see those as, two of the main reasons that gets cited. The third reason is, and this falls back to having a history or having evidence of a correct diagnosis of schizophrenia when the resident is, or a similar type condition, when the resident is receiving the antipsychotic medication. Those tend to be the three main reasons we're seeing that.
I'm afraid I didn't quite follow the last one, the schizophrenia. Could you restate that? I'm sorry.
Yeah. So with this part of the requirement, um, we're looking at the presence of schizophrenia or a schizoaffective disorder in the person's history. I think there were, and I don't know that we see that this much in Colorado, but I think there have been instances where somebody who's newly admitted has a brand new diagnosis of schizophrenia that may not be supported by history or may not have been provided by a psychiatrist. And so then the question is the diagnosis present to support the administration of the antipsychotic medication, or does the condition exist for which the resident, either historically or by the proper process of diagnosis, is the medication being administered for the symptoms of that standing condition?
Perfect. Thank you so much. All right. Well, good. Well, thank you so much, Chad. If anyone else has questions too, you can always feel free to email us and we can always pass those along as well. All right. Well, finally, our last part of our presentation today will be, we have Atana Lamb and Nicole Semler, both are PharmDs that graduated from the Colorado School, the SCAG's School of Pharmacy. They also completed the Neurology Research Fellowship, which is a 2-year fellowship. And so they have a lot of great background and often in our space we're doing a lot of management of these meds because it is so hard to get into neurology these days. So we are really grateful that they are here today and kind of help share an overview of seizure management. So thank you for being here, ladies.
Thank you
Thank
for
you.
having us.
Yeah. All right. Hello, everybody. So my name is Itana. I have here my co-host and also my used to be co-fellow, Dr. Semler. She is now working in South Carolina as a clinical pharmacist in the hospital, and I'll be finished this year as well. So hopefully, please, if you see me, feel free to say hello. Nicole will be handling the slides, so I'll be asking her to click at certain times. Please keep in mind, we do have a quite loaded slide deck, but we are trying to be conscious of the time, so we may be going a little bit fast. Please feel free to send us questions through the chat, or feel free to stop us if there's anything you would like to discuss. We'll be free and happy to do so. But yes, thank you. Currently, we also do not have any actual or potential conflicts of interest or any disclosures in relation to this presentation. Our objectives, as you can see here, the first one is to design a monitoring plans according to a patient's seizure medication regimen. And then secondly, we'll be adjusting medication dosing according to a patient's renal or hepatic status. 3, identify common interactions between an anti-seizure medication of choice and other commonly used medications. 4, design an abortive medication regimen appropriate for the patient's status. 5, develop a plan to switch patients from an oral medication to an injectable or oral solution option. Okay, so here we have on the left, as you can see here, I've grabbed this graph from a published 2017 cohort study where they took 5 cross-sectional cohorts, including residents in basically all of Medicaid and Medicare at the time. So this is from 2003 to 2007, almost 98% of nursing home residents at the time. Through this cross cohort study, they were able to find that proportions of patients, essentially the prevalence of epilepsy or seizures in the nursing home population was greater than 7-fold higher in comparison to community dwelling patients. And also in the study, if a patient had a comorbid neurologic condition, they were 7 to 30-fold times higher to likely have epilepsy or seizures. So some of these comorbid neurologic conditions include stroke, also hemiplegia, traumatic brain injury, primary brain tumor, Alzheimer's disease, dementia, and Parkinson's disease. Another 2 risk factors to include are diabetes and seizure medications. Sorry, diabetes and hypertension. As you can see, though, interestingly enough, they did find a decreasing association of epilepsy and seizure with age. So patients within the 65 to 75 years of range had a 3.8-fold higher chance of epilepsy or seizures in comparison to participants older than 85. And same within the 75 to 84 years of group, patients had a 1.9-fold higher chance than the older group of 85 years. Another important, significant statistic to mention is that 22% of inpatient admissions for seizures were discharged to long-term care facilities. So just keeping in mind that seizure and epilepsy is very prevalent in nursing home populations. Next slide, please. Thank you. So for monitoring anti-seizure therapies, especially when you're prior to starting a medication, liver enzyme tests are very, very important. So liver enzymes are usually markers of hepatocellular injury. So ASMs, some ASMs, not all of them, may cause something called drug-induced liver injury, also known as DILI. Therefore, regular liver function tests are usually recommended for the higher risk medications. So you usually would like to avoid combining hepatotoxic anti-seizure medications with other hepatotoxic agents, but Nicole will go into further details about this point, about the liver damaging agents. Other labs to consider are the comprehensive metabolic panel, the complete blood count, and the platelet count, and also with the neurologic exam and a patient report. Interestingly enough, anti-seizure medications for serum levels usually would want to collect them at the trough. And this is due to the short half-life for most anti-seizure medications. I will go into further detail as to which ones do not. And you're going to always want to monitor for rash, specifically Stevens-Johnson syndrome, DRESS, also known as drug reaction with eosinophilia and eosystemic symptoms, or any systemic involvement symptoms such as diarrhea or nausea and vomiting. As you can see on the right in the image, right here, we just have kind of the generations of how anti-seizure medications have evolved over the years. All right. So I know this part may seem a little bit overwhelming because we will be just going, this on the slides will be mostly just serums, but this is mostly just an important reference for everybody to utilize, as serum levels are very important to obtain, especially when the patient is seizure-free. Usually this will serve as a benchmark for future references if seizure control deteriorates, such as if the patient has breakthrough seizures or symptoms that may just suggest of development of toxicity. There are fluctuations in general for drug levels depending on the patient. So some internal factors may be due to the pharmacokinetic effects in absorption, distribution, metabolism, and excretion. But there are external factors that can also affect the fluctuations in drug levels, such as diet, other drugs, or nutritional status. So it's very important that patients stay within range and try to get back into range. If they do veer out, it may be considered insufficient efficacy for this therapy. So some of the important parts I just wanted to mention here is for phenytoin, make sure you obtain the serum 5 to 7 half-lives. So that's usually 7 to 10 days after treatment initiation, dosage change, or any changes to the drug regimen. And as you can see, the safe range is around 10 to 20, but toxicity can be shown at greater than 40. Another one to watch over for is valproate. Valproate is also very crucial for monitoring levels, specifically for toxicity. Intervals for this medication are every 2 to 4 hours. Usually, you would like to observe the serum until there is a decrease in the valproate levels. Then you would consider that the patient is in the safer range. All right, next slide, please. As you can see here, there are more serums, but the most important part we would like to mention is the carbamazepine. So carbamazepine, similar to oxcarbazepine and oxcarbazepine, they're autoinducers. So carbamazepine can autoinduce its own metabolism. This usually starts within 24 hours of the start of therapy and can continue 3 to 5 weeks of treatment. So you usually would like to delay the first measure of your carbamazepine until 4 to 5 weeks after this autoinduction phase. So it may require some higher doses to maintain a steady concentration if using with other anti-seizure medications, because those can also induce carbamazepines, inducer metabolism. For levetiracetam, also known as Keppra, just an important, a fun note, even though there's levels of 12 to 46 micrograms per liter, in micrograms per milliliter, it's been a little different at 120. But that's seen in acute mania. For levetiracetam specifically, these levels should also be drawn before the morning dose for the best interpretation of concentration, also because of its short half-life. And also, if you were to wait a little bit, hydrolysis can occur, which would result in falsely lower concentrations. A medication, lamotrigine, something to mention is to prefer to be avoided for acute seizure, and usually this is due to its long onset. Unless it's used to bridge two anti-seizure medications together, lamotrigine can have a onset of 6 weeks. And lacosamide we have here on the bottom is just an adjunct. Okay, so moving on to the next slide, please. Thank you. So we'll have is levetiracetam, also known as Keppra. These are specific monitoring side effects or adverse effects you should watch out for usually, and we try to highlight ones that would be more likely to be seen, especially in the older populations. So for Keppra specifically, behavioral abnormalities, so you're going to watch for psychiatric or non-psychotic symptoms such as aggression, irritability, or agitation. Somnolence and fatigue can occur as well, but coordination difficulties were something we wanted to highlight. These could be resolved after the first month. So just something to watch out for, especially for falls or imbalances. Next we have is valproate, or also known as Depakote, making sure for patients that they have appropriate nutritional and fluid intake, as dehydration can be an adverse effect. And somnolence may occur more likely, which is dose dependent when you increase the dose. Another point with valproate is that it's more likely to have hyperammonemia than topiramate, as you can see on the bottom. Usually, this can occur 2 to 3 times elevation of ammonia with valproate therapy. It's usually insignificant, but it's best to be cautious of patients with potential coexistent liver diseases. So continue to monitor for this patient or switch the AED if increases of these enzymes continue. Other ones are tremor, weight gain, or hair changes. Another one is Parkinsonism. Parkinsonism is something to watch out for in advanced age to be able to distinguish or differentiate between Parkinson's disease and epilepsy treatment, adverse effects. So for topiramate, we have here also has hyperammonemia, as I spoke on before, but also to monitor for serum bicarbonate. Kidney stones are very highly prevalent with topiramate, so hydration is very much key. Moving on to the next slide. We also have is phenobarbital. Phenobarbital is a likelihood of QTC prolongation, so ensure your patient's monitoring their electrolytes and getting their ECG checks as well. Phenytonin and lamotrigine are very similar to topiramate, so hydration is very important. Kidney stones are very likely with these medications as well. Lacosamide, similar to phenobarbital, you would like to monitor their ECG prior and after titration, not because of QTC prolongation, but because of PR interval increase. So watching the cardiology of the patient is very important here. Gabapentin and pregabalin are very similar medications as well. Something to watch out for are patients with edema. So be cautious with patients with later stage heart failure or in concomitant use with diazonidinediones agents. This could lead to also exacerbations of those heart failure. All right, thank you. Next slide. So next we have our the top box carbamazepine, eslicarbamazepine, and oxcarbazepine. As you can see, they're all very similar in this similar class of medications. They can have cross-reactivity. So it's very preferred to not ever use them together. So don't use oxcarbazepine with carbamazepine. It's a very likelihood that this may occur. Another point to watch out for is hyponatremia. Hyponatremia is usually the most likely with oxcarbazepine, but in comparison, oxcarbazepine is actually the most well tolerated out of all the three. So hyponatremia is very common in older ages, especially older than 40 years of age, and medications that can also cause hyponatremia. Another point to mention is that syndrome of inappropriate antidiuretic hormone secretion can also occur with this medication due to the direct stimulation of the hypothalamus. So for prevention, you could use the lowest effective dose, monitor sodium, or consider an alternative for a patient. For carbamazepine specifically, I have it highlighted here as constipation is a very high likely side effect. So making sure your patient has appropriate fiber and hydration as well. Next slide, please. Thank you. So for the influence of anti-seizure medications on bone health specifically, it is seen that in epilepsy population in general, this could include even children as well, which is why they've kind of dug deeper into this as a 2 to 6 times greater risk of fractures in comparison to the general population. There's the assumption that, oh, it's maybe because of advanced age, but because children were included into these studies, they have been shown that anti-seizure medications themselves may cause lower reduction of per se. As you can see on the right, the yellow chart, reduce in serums of calcium, phosphate, vitamin D levels, and may elevate parathyroid hormones, marker of bone formation, and markers of bone resorption as well. But including with advanced age, if we're going to include the gradual decline in bone mass and bone itself, it's very important that there's increased risk of osteoporosis and fractures to monitor within these patients. Generally, they have not been able to solidify exactly why anti-seizure medications cause an increased risk of fractures. Some of the theories right now are that the P450 system has led to an increased catabolism of vitamin D levels, but this doesn't explain all other medications because some medications such as valproate is an inhibitor, not an inducer. Other theories include is that hyperparathyroidism, calcitonin deficiency, or basically just interference with the intestinal absorption of calcium with the medications. So making sure your patients are having prophylactic measures against osteoporosis is very important, especially as adequate supply of calcium and vitamin D, having a balanced diet with protein and regular exercise would be really great for patients. Oh, thank you. So other indications for anti-seizure medications, what we have here is basically a great resource to view or guide yourself per se if a patient is having other comorbidities. Per se, neuropathic pain. Gabapentin and pregabalin are also used as anti-seizure medications, but they can also be used for neuralgia. So it's kind of hitting 2 birds with 1 stone. Same with levetiracetam, head-related injuries to prevent seizures, oxcarbazepine also for neuralgia, but for bipolar disorder per se, valproate or carbamazepine could be also used. Over here on the right-hand side, we kind of have them more grouped by comorbidities. So for osteoporosis per se, you would like to avoid these certain measures such as carbamazepine, phenytoin, and phenobarbital. but with obesity, also avoiding valproate and tritopyramate, leading to valproate may be causing weight gaining issues. Congestive heart failure as well. You should caution with pregabalin, as we spoke about the potential edema or worsening of congestive heart failure with pregabalin and gabapentin. And essential tremor per se can be used with topiramate or primidone. And migraines as well could also use with topiramate. And next slide, please.
All right, so now we'll get into renal dosing adjustments. This is going to be a lot of information. You're probably not going to retain most of it, and there is absolutely no shame in using Micromedics or Lexicomp. I still use it every single day just to double check myself. These are some nasty drugs that can have some very bad consequences if we don't get them dosed correctly. So again, there's absolutely no shame in just looking these up from time to time. But just to kind of go through quickly, levetiracetam, this can depend on the institution. I know that we have an institutional policy about dosing and renal adjustments, but really the extended release, just once daily dosing. So for the 80 to 50 range or creatinine clearance, we're looking at 2,000 milligrams. And then really just want to bring your attention to the immediate release is just half that dose. So we take that 2,000 once daily and we divide it up into 1,000 twice daily. And that goes down the list. But the only thing for immediate release that is different to the extended release is that if we get someone below 15 creatinine clearance, we can go to once daily dosing for that, and that's that 500 milligrams once daily. Phenobarbital, this is one that we don't really worry about for renal dosing, so it's really when they get to an eGFR of less than 10, we go to 50% of the dose with a max of 200 milligrams a day. And then lacosamide is another one that they have to be pretty bad off before we really start adjusting it. And even then, we really only reduce the dose by 75%. And there is a difference between the extended release and the immediate release, with the extended release having a max dose of 300 milligrams a day and the immediate release having a max of 450. Valproate, the free valproate clearance when someone gets under 10 creatinine clearance can be reduced by up to 30%, but this is a big one that we do want to look at serum concentrations, so really following those. Carbamazepine doesn't have any adjustment necessary when we're going into renal dosing. Eslicarbamazepine is when it's less than 50 that we reduce the dose by 50%. And then oxcarbazepine, it's when we get down to less than 30 that we start at 300 milligrams a day and that we increase that by 300 milligrams or 450 milligrams weekly. If someone is on dialysis, we need to use the immediate release formulation just because it will stay with them, just like an extended release would. Lamotrigine, there is no renal dosing adjustment per se, but we do know that in the advanced age population, clearance can be lowered by 27%. So really just looking out for any side effects with that if they do start taking the dosing down and seeing if that helps. Topiramate, this is when it's less than 70 creatinine clearance. We reduce the dose by 50% with a max of 200 milligrams a day. And then we can also go off of GFR. If it gets from 60 to 15, then we do 100 milligrams twice a day, and less than 15, 50. And then phenytoin is a great one because we don't have to adjust it, but you do have to look at serum concentration just to make sure nothing's going awry with that. And then, as Atana said, gabapentin and pregabalin are very much twins. Um, so gabapentin is another one that we have an institutional policy. I don't know how everyone else is, but we prefer immediate release and renal dosing, but extended release is a possibility. Extended release, we really only use it when a person is 60 to 30 creatinine clearance, and we start at 300 milligrams once daily, and that can go up to 1,800 milligrams once or a day. In divided doses if you want. And then immediate release is where we really stay the 50 to 39 range. We're at a max of 1,400 a day. When we go to the 29 to 15, we half that to 700 milligrams once daily. Once we hit 15 milligrams, or sorry, 15 milliliters a minute creatinine clearance. So we hit 300 milligrams once daily. And then less than 15, we do it proportionally to the creatinine clearance. So say they have a 7.5 creatinine clearance. Since that's half of 15, we'll do half of whatever dose they were on. And then pregabalin, when they get to 60 to 30 creatinine clearance, we reduce it by 50%. So really, it's more of a 300 milligram a day dosing. You can either do that twice a day or 3 times a day, whatever the preference is. And once we hit 30 creatinine clearance, we want to switch over to the immediate release with a max of 150 milligrams a day. But if it's less than 15, we really want to stay away from the extended release, and we have a max of 75 milligrams a day. Again, this is a lot of information, and I would always double check if there is a question of what the dosing should be with their renal function. So for hepatic dosing, we do have 2 hepatic offenders, and I try to put them at the top of the list. I really try to make this a quick guide where the worse the Child-Pugh class is, the higher it is on the list to kind of say to not use it. So phenobarbital, no matter their status, it's contraindicated just because it is such a bad hepatic offender. Carbazepine is also a bad one, but it's really stated to not use in severe impairment. So that is whatever your clinical judgment is as what is severe. Um, and then the rest of the list changes depending on the class. And just for time, I'm going to kind of go quickly through it. But the ones to really look at or to know for our hepatic status patients is phenytoin, again, really going off of those serum concentrations. That is such a big one, but we don't need to do any adjustments for that. And then levetiracetam, gabapentin, pregabalin, and topiramate are also ones that don't need any adjustment. So there are interactions between anti-seizure medications, and since we use so many at the same time, it is good to be kind of aware of what some of the big offenders are. So lamotrigine is one that can change quite abruptly with the addition or subtraction of other anti-seizure medications. So ones that will lower lamotrigine levels is phenytoin, primidone, carbamazepine, oxcarbazepine. So when we either start or start lamotrigine, we want to double the dose of lamotrigine, or if we take that off, then we want to half the dose. And then ones that will increase lamotrigine levels is valproate. And so when we start lamotrigine with that, we'll do half a dose and then we'll titrate twice as slowly just to watch for any side effects. Topiramate, it is affected by a lot of drugs. So carbamazepine, valproate, phenytoin, phenobarbital, and lamotrigine can decrease topiramate levels, so increasing that. And then lacosamide is a big one. It interacts with a lot. So when we start carbamazepine or any of the penes, phenytoin, topiramate, or valproate, we actually want to reduce the dose of any of those if we're starting lacosamide. And then some interactions, again, big list of which one is an inducer, what's an inhibitor. Again, lamotrigine with itself inducing, that we have to wait a few weeks to get it to kind of act right. But really wanted to highlight the big interactions of the medications that we use. So for pain medications, this is our tramadol, our meloxicam, our opioids. We may need higher doses of those pain medications when we're using them 3A4 inducers. So basically going off the chart, the mazepines, phenytoin, and topiramate are our big ones to look for with that. And then antidepressants, we prefer the use of SSRIs, and that is just because TCAs or tricyclic antidepressants can actually induce, or they lower the seizure threshold, so they can per se induce seizures. So really want to avoid those. And duloxetine does have a low to moderate risk of inducing seizures as well. And so when using those together, just want to check those interactions and monitor for any emergence or worsening of depression, suicidal thoughts, or behavior changes. And then for antipsychotics, we start with lower doses of risperidone, quetiapine, or riprazole. And then if we do have a transplant patient, that is using tacrolimus or any other immune suppressant, watching those serum levels very closely. And then when to stop ASMs. This is something that we see a lot. So, when a patient has been on an anti-seizure medication long term, we usually say that if they've been seizure free for 2 years, or it can be 5, it depends on the neurologist that you talk to, but 2 or 5 years, and there's no seizure activity on the EEG, that we can consider a trial off of ASMs. The exception to that rule is that phenobarbital must be tapered very slowly, just because in itself, taking it off can induce seizures. So, making sure that we're covering ourselves, that we're not throwing the patient into a seizure because we're taking that off too slowly. But then there are some predictors of seizure recurrence. So how long they had epilepsy, what age they were, if they were an adult, they have a higher risk. How many seizures did they have before? If they are focal seizures, how many ASMs they were on before we started this withdrawal and this taper off. If they're the female sex, or if they have a family history of epilepsy, we have a higher chance of reoccurrence. And then one of our big ones, I know in our ER, we love to give Keppra if there is a mechanical fall or any type of brain trauma. We give either a gram or 2 grams. It really depends on the weight of the patient. But we use that for seizure prophylaxis. But when does that come off? And so we looked at studies, and basically after 7 days, it should be stopped. And if there are seizures that are occurring after 7 days, that's when we'll think about long-term use. And that really just comes from a study that they looked at phenytoin, saw that really after the first week, it wasn't helping much. And then there was another study that looked at Keppra and phenytoin to see if they were the same, and there was no difference. So took that, put that to Keppra, and said basically any type of prophylaxis, do it for a week, and then take it off.
All right, so for seizures first aid, number one part, please notify the attending nurse practitioner, physician's assistant, or physician as soon as possible. And importantly, do not leave the resident alone. So turning them on their side, using a pillow or support under their head, and never put anything in their mouths. Especially if they're foaming, do not wipe away the foam. Administer their first aid medications or seizure medications as quick as possible. Making sure that just a general outview is that the post-ictal state usually lasts a couple minutes to hours, and those may include confusion, difficulty thinking, anxiety, headaches, or soreness as well. Also may also include psychiatric symptoms that can last up to days. Residents with seizure disorder, so recurrent or repetitive seizures, include ones that are lasting longer than 24 hours or have 3 more seizures without regaining consciousness, is potentially maybe status epilepticus. So potential risk for delaying treatment would also be increasing the risk of status epilepticus for the patient, and extending the seizure duration may also lead to functional disability and death. So making sure that we're treating the patient as soon as possible. And please consider emergency services, especially if the patient has prolonged seizures, injury, or is cyanotic. All right, thank you. Next slide, please. So here are some abortive options that you can utilize to making sure that you're treating the patient as soon as possible. First line would be benzodiazepines. Lorazepam, as you can see in this yellow box right here, is the first line, usually for IV or PO. We've included the dosing as well. However, a important note to mention is do not use lorazepam with valproate. Valproate can increase lorazepam levels and can lead to adverse effects like drowsiness, dizziness, and even coma. So it's best to avoid valproate with lorazepam. On the bottom we have here is diazepam. Diazepam we usually prefer to be avoided use in older patients, and the reason why is because of its long half-life. And with its long half-life, side effects are also very likely to occur for patients as well, such as cognitive effects or imbalances. So diazepam is usually not preferred in this population. And midazolam, as you can see on the bottom, is another option that can be used. Usually preferred is IM. Please keep in mind, we have on the left here also FDA approved Anti-seizure medications for specific conditions such as seizure cluster rescue. We have Diastat, we have Valtoco and Nazalam. These are intranasals or rectal gels. For status epilepticus, FDA-approved treatments are usually IV diazepam or IV lorazepam. All right, and then,
Okay.
oh, sorry, one other point, Nicole. Oh, wait,
Oh,
making sure that you're using these preferred medications because of other medications aren't studied as well. So there are variations with absorptions and onsets in comparison to these benzodiazepines that are mentioned now. But yeah, that's all. Thank you.
and I do know that we have, at least right now, a shortage of lorazepam. Really, hopefully not a worry for you. There are other options, but if the seizure is still continuing after either first dose or any of these nasals, hopefully they are kind of taken somewhere else so you won't have to worry too much about them. So there are options for trouble swallowing. Basically, a rule of thumb, if someone is on an extended release or delayed release medication, it cannot be crushed, but immediate release medications can be crushed. The only exception to that is carbamazepine delayed release capsules. They can be open, but the spheres or the pearls that are inside, we don't want to crush those. There are oral syrups and solutions. I've listed out all the options. We have a lot of options for that one, but the IV options are lower. So we have lacosamide, Keppra, phenobarbital, phenytoin, and valproate. Just something that I really want to emphasize because I've seen it a lot in practice is when we go from either an extended release or delayed release medication, going to the IV options or the oral options, those are the immediate release and they can have a frequency adjustment that we need to make. So like with the valproate, if they're on Depakote ER at home, they're usually only taking it once or twice a day. But with an IV option, we're looking at 3 to 4 times a day. So just something to be aware of. And then switching ASM formulations, a lot of it is a one-to-one conversion. The only time that we change is when we go from Depakote ER to delayed release or vice versa. These are not equivalent. So if we're going from delayed release to extended release, we're usually increasing by 250 milligrams, but you really can go in the range of 80 to 20% of the, or on top of the delayed release dosing. And that's just based on if they're having a response or not to their current dose. And then valproic acid, it's a weird one. When they're on the acid form of valproate, it has a dose increase of 10%, but when they switch to sodium, they can be decreased. And then that valproate sodium can be directly switched to Depakote delayed release, but not the extended release. So a really sticky one. I do recommend looking that up again, just because these are very weird drugs to be working with, and there's a lot of nuances to them. And then all the mazepines, the only one, they're usually one-to-one. The only one to really look at is carbamazepine to eslicarbamazepine. The carbamazepine will be increased 30% on top of the carbamazepine dosing. And theoretically, this switch could be done overnight because they are really the same parent drug, but we usually do it over 1 to 2 weeks just to make sure we got the dosing right. And I know that we are at the end of our lunch, so if you guys have any questions, please feel free to either email us, leave it in the chat, send it along to someone to forward to us. We will try to answer as many questions as we can. And then there are references.
My gosh, ladies, that was amazing. I think it's just affirmation of how much we value our pharmacy colleagues because we cannot do this care without you all. So thank you for that. Especially somebody did have a question about the prophylactic dosing. We see that all the time, that it doesn't get discontinued at the hospital. So just those few pearls are just so helpful for us. So yeah, we're happy to forward any questions that y'all have, just send us to the questions and we'll pass them along. So thank you so much, everyone. I hope
Thank
you
you
had
for
a
having us.
Yes, thank you for
Yes,
having
thank you
us.
for
We enjoyed it.
yeah, we love having you. So thank you so much. Everybody have a